Today, I'm pleased to introduce Dr. Katherine Ritchey. Dr. Ritchey has experience in developing and leading clinical innovation programs that serve the domains of health most salient to older, complex adults. This includes a special focus in mobility-related interventions like fall prevention in community-dwelling older adults, access to care utilizing telemedicine modalities, and best practices for asking and acting on what matters. In addition to her local clinical innovation implementation work, Dr. Ritchey also oversees a collaborative learning and mentorship initiative funded by the Office of Geriatrics and Extended Care around the integration of patient priorities care into multiple VA clinical settings. I think you'll hear about that. She has a lot to share with us about age-friendly care, assessing and acting on mobility. Welcome, Dr. Ritchey.
Great. Thank you so much. I really appreciate the introduction. That was very kind of you and the offer to talk to everyone today. So as mentioned, we're going to be talking a little bit about how do we assess and act on mobility in the context of an age-friendly care setting. So my disclosures, I have no financial conflicts of interest to disclose, and the viewpoints and opinions that I will share are strictly mine and not reflective of the Veterans Health Administration. So our learning objectives for today are to be clarifying some differences and similarities between mobility and fall risk assessments, recognizing evidence-based IHI preferred assessment tools for mobility, and applying the patient priorities care framework for what matters to identify and align the care to mobility-related goals. So age-friendly healthcare systems aim to follow an essential set of evidence-based practices known as the 4Ms, cause no harm, and align care with what matters to older adults, their families, and care partners. The concept of what matters is the keystone M of the 4Ms of age-friendly care because it's the ability to guide treatment towards the unique health outcomes that matter most to a patient, and also for the ability to inform the other 3Ms of age-friendly care. Effectively, your care practice and/or system of care is only age-friendly when you act on what matters to older adults. So why focus on mobility? Studies exploring health goals and care preferences of older adults have indicated that most health outcome goals are inherently related to the preservation of mobility. Examples include ability to play with grandchildren when they visit, shop and perform household chores, walk as exercise, or stay in home and care for self and to live independently as long as possible. The STRIDE study is an example which examined the efficacy of multifactorial falls-based interventions, found that 95% of participants prioritized risk factor interventions that addressed impairment in lower extremity strength and balance or gait. Even observational data from my own geriatrics clinics here at VA Puget Sound has also found that over a third of veterans select mobility as one of their primary functional goals that they want to work on. This prioritization makes sense. Independence and mobility is essential for independent living. As mobility declines, there is impact on our physical health with deterioration in chronic health disease and increased risk of frailty. Additionally, immobility can lead to social isolation, reduced sense of purpose, and ability to participate in the activities that matter most. Therefore, it's important as clinicians to ask and act on mobility challenges facing our older adults. When I conceptualize immobility and following risk, I kind of think about it on a continuum. There are changes in mobility that eventually lead to an increased risk of falling. So they're inherently interconnected and almost bidirectional. As mobility declines, this can also lead to a fear or hesitancy and restriction of physical activities. That further leads to a decline in muscle strength, coordination, and imbalance. That restriction also sometimes has additional psychosocial and psychological consequences as well. Immobility and subsequent sarcopenia is a major risk factor for fall and fall-related injury. And we know that falls and fall-related injuries are the leading cause of morbidity and mortality for older adults. Falls and fall-related injuries are the most common causes for decline in ability to care for oneself and to participate in physical and social activities. We know a third of those with fall-related injury will newly require help with activities of daily living. And over half of those who have their new required assistance for ADLs will at least need that for 6 months or more. And we know that more than 95% of older adult hip fractures are caused by falls. So essentially, we see this kind of downward cascade effect that starts with some changes in mobility that can eventually lead into falling risk that eventually can lead into frailty. And really our job is to not only recognize and see this kind of cascading effect, but find ways and think about ways that we can reverse this domino effect. Though risk factors for falls and the result of mobility impairment are similar to falling risk, and there is this interrelationship, there are some distinct differences when assessing a person's mobility versus evaluating them for the risk of falls. Unlike falls, mobility assessment should be more goal-oriented and proactive, and within that, a proactive discussion. Rooted by activities that matter most to a person. So for instance, being able to garden or go on trips with a family or play with their grandchildren. A person might actually be more inclined to share mobility concerns and be receptive to mobility-related interventions, more so than falls-based discussions. The intent when we talk about mobility is to recognize a person's strengths and their interests and promote activity that aligns with those preferences to achieve a specific goal that is, again, connected to doing more of what matters to them, and with that, being more physically active. Discussion on the flip side about falling risk can sometimes be actually stigmatizing for older adults. There are many myths related to falling risks. That, for instance, it's inevitable with age. That is a normal part of aging. That there's a lot of worry about talking about falls and sharing about falls with healthcare providers because it will lead to reasons for loss of independence or restriction of their independence or placement and institutionalization. And so therefore, it can sometimes lead to recommendations which actually limit or restrict physical activity, rather than promoting adaptive mobility. As previously mentioned, falls are a downstream effect of long-standing mobility impairment, and therefore a reaction to physical functional change that has likely been present or developing for months or even years. So instead, by viewing mobility from an age-friendly perspective, we can better partner with older adults to engage in the therapies, which will help them do the activities that they want to actually be doing, and thus increase motivation for positive behavioral change. There are several ways to assess mobility. I am not going to go through all these different new tools and all the nuances and the different things about them. However, they are listed here for reference. The IHI age-friendly website and the mobility toolkit that I have a link to on this slide, found on the age-friendly website, is a very helpful resource should you need to know more about any one of these tools or figure out which one might work best for you and or your clinical setting and team. What is most important is to literally pick a tool and stick with it and become consistent and proficient in it. They're all great. They all have their benefits. They all have their challenges, but most important is to look through them if you're not already doing one of these, and then find whatever works best for you and your team. Only one evidence-based assessment tool is required to meet the minimum requirement for age-friendly recognition. And just what that looks like, it looks like here. So here's an example of when you go through the application process, for instance, for age-friendly recognition, and you yourself and your team and your clinical setting is interested in obtaining age-friendly recognition, this is what you'll be going through. And as you'll see, there's both the opportunity to list which of the tools that you're using and to also list how you act on mobility once identified as well. So, excuse me. So now I'm going to use a case to kind of help put this all together. Is how do we assess mobility and think about mobility? And then not only that, but how do we do it from an age-friendly perspective to really put it in the context of what matters? And how do we use that to really lead in understanding healthcare preferences and priorities of a particular person when selecting interventions to help address those concerns related to mobility. So we'll talk about Mr. C. So Mr. C is a person with several health disorders, including atrial fibrillation. He has chronic kidney disease, stage 3. He's got several different musculoskeletal issues, including chronic low back pain due to his degenerative disc disease. He has plantar fasciitis, depression, hypertension, hyperlipidemia, COPD, and some hand arthritis as well. He lives at home alone in a single family house, and he's got 5 steps to enter his main entrance. His inner circle of support include a faith-based community and a family. He has a local child and grandchildren too that are very important to him. He has several hobbies that generally get him out of the house. He loves to garden. He loves time outdoors. He loves being out in nature. He's a true Pacific Northwesterner. He loves taking pictures as well. And he uses his opportunities to go outside to really exercise his photography talent and interest. He's still independent in all of his ADLs, but admits that it's starting to get more difficult to do some, kind of the functional tasks such as grooming and putting on of clothes and even bathing at times. And he's starting to feel more unsteady and uncertain about doing those. He's no longer driving, but he takes he is able to do his medications and for the most part do his household chores without a ton of difficulty. And then you see his list of medications there. He's on several CNS acting medications, as well as kind of your typical medications for some of the chronic diseases that he is on. He already has several devices at home and medical equipment. He's fortunate to be in the VA where we're able to offer things such as like shower chairs and grab bars and reachers. He also has a medication organizer to help him remind him and organize his meds to keep them straight. He regularly comes in for his primary care appointments. He rarely misses them. He prioritizes, again, engaging in healthcare. And he generally likes to do, in-person visits, but he can and has occasionally done some video visits and is open to that as well. And in talking to him and exploring some of the activities that matter most, like particularly some of those hobbies, he actually admits that he hasn't been going out to his photography group as much as he was. He's starting to feel a bit more unsteady, especially with walking on over unstable ground. He has more uncertainty about getting up and down those steps like he previously was. And so instead of going out like it was about 3 times a week, maybe about 4 or 5 months ago when you last saw him, right, to take pictures and meet with his group, he right now is barely leaving a house. He only does it if he needs a grocery shop or go to medical appointments. And then as far as when you examine him, you notably see that he's got a bit of kyphosis, kind of seen pictured there. He's got some bony hypertrophy, particularly in his knee joints. He's got sarcopenia roughly in his lower extremities and a little bit in his arms. As I mentioned, he's got orthostasis too when you're doing some blood pressure checks. There's loss in sensation both of his feet. He's got extension of his lumbar spines, also kind of throwing off again his posture when he's walking in an unstable gait, and his timed up and go is 15 seconds. So in the chat, if we're able to do this, I'm curious if people can maybe list some of the things that might put Mr. C at risk for a mobility impairment. And in this case, falling risk too. I'll see if I can look at the chat. If you can remember, I can go back to the other slide. I'll go back to the other slide real quick. Just to help people out. Oop.
Anybody want to add something to the?
Oh, there we go. Yay, thank you, Ivan Wang. I appreciate that. Way to play along. There we go. Steps. I like that. The CNS meds, including gabapentin, one of my favorites. Yes, back posture. Very good. I should preference I'm a DO, so we think a lot about structure and function and posture. So thank you. Age imbalance, yes. Age is a risk factor, though, as we mentioned earlier, falling is not normal aging. It's just more common. Orthostatic hypotension, excellent. This is great. Thank you, everyone. Thank you for playing along. So yeah, so we're gonna share some of the things. So yeah, so his chronic low back pain, just from a history standpoint, his plantar fasciitis, his depression, particularly depending on how much or any of those things are present at any one moment or consistently present, day to day. Meds, he's on several. The blood pressure meds are always a little bit questionable, but if they're causing orthostasis, they're probably contributing to his mobility challenges and particularly falling risk. And then on several of the CNS meds that he's on, particularly gabapentin at a pretty healthy dose, as well as tramadol, which we in geriatrics like to call tramadont. In his exam, like pretty much everything on his exam is positive. And so in summary, too, the other thing about Mr. C is that he is a very complex, actually kind of individual. He's someone that I would term as a person with multiple chronic conditions. And sometimes when we're faced with older, complex adults, it's really important to recognize that they actually vary a bit in what is important to them and like their actual health outcome goals. About 42% overall value function over extended survival, or about 32% prefer symptom relief, while another third prefer to actually live longer, regardless of function. And so because there's so much variance in the willingness and in what people's health outcome goals are and their goal preferences and their willingness and ability to do things and health tasks that are asked of them, it's really important to sometimes sit down and start to ask these questions about what matters, because it helps give us a guide. And a lot of times with a person like Mr. C, it's often really hard to know where to start with them, outside of just going over, his actual laundry list of health problems. That's a pretty typical approach to a person with multiple chronic conditions. We monitor their traditional health outcomes. We monitor their A1C, their blood pressures, their weights potentially. But I think what's really important to recognize is that none of those are unlikely to directly impact the issue that matters most to him, which is his inability to go outside and do photography. Maybe indirectly, clearly like a person has orthostasis, if you're adjusting their blood pressures, you might make some impact there, but it's kind of missing the bigger picture, and it's missing all these other things that could be contributing, and or things that he could possibly start to spend his time and prioritize his time in getting into to help improve his mobility. So given that traditional disease-based outcomes are often not person-centered, it may not be reflective of what matters most. It's really helpful to actually reframe our approach with older adults and instead lead with questions that not only explore what matters, but actually frame recommendations by their health priorities and preferences. So in a person with multiple chronic conditions, there's always uncertainty about benefits and harms of individual treatments given competing conditions. There's uncertainty about which conditions are most affecting what matters to a person and what is the right treatment for him or her and their offending conditions. And there's often no right or best option. Thus, I know personally, even as a physician, and I think this is true of many health professionals, we're left wondering kind of where to start and how to do person-focused care, particularly when that person-focused care might actually conflict with disease-based kind of care and or algorithms. However, by asking what matters, we start to uncover areas of friction potentially that are causing non-compliance or non-adherence. It also can uncover discord or disagreement of taking certain medications or doing certain treatments because again, we're focused on different things. Oops, sorry about that. For instance, a patient might be really focused on how they're doing today and the symptoms that are bothering them today. As an example, they might be getting too dizzy from their blood pressure medication. And that's the most important thing to me versus a clinician who's, again, kind of thinking about, more the intermediate or long-term, outcomes, such as, managing their hypertension to prevent stroke or heart failure. And so therefore they're like kind of thinking about, well, I need you to take this medication because we have to lower your blood pressure in order to reduce your risk of stroke. That's, again, a longer term goal. So a lot of times the clinician is concerned, again, about these long-term goals versus, a person who instead is maybe focused much more about the intermediate. So instead, by learning more about the person and their goals and preferences and priorities, it actually helps determine not only what's effective medicine, but the best medicine for them and their situation. Linking what matters or their values to health outcome goals, we can better clarify treatment options that are the most appropriate or doable for an older adult and their care partner, and help them select treatments which provide more individual benefit and hopefully less burden or harm. When there are so many competing illnesses and those associated guidelines, focusing on symptoms which are preventing that person from doing what matters most to them can actually help make the clinical encounter more efficient and productive for both you and the patient. It also helps build trust and rapport because you're actually listening to them and their values and their goals and the impact that their illnesses have on their life. It's really helpful to frame health outcome goals into what is realistic and doable in the context of the person's life and their abilities and their trajectory, again, of their combined illnesses. Sometimes it does require some exploration into their health preferences, the things that they're willing and able to do or the things that they're not willing or able to tolerate or do. And so working through all of these different components, you can actually help you form clinical recommendations that align care with that is very person-centered. So what I've just summarized is effectively the patient priorities care approach, and it is the what matters for an age-friendly system. It is a process where we do the identification of health priorities to establish the foundation of care alignment. It is endorsed by the Institute of Healthcare Improvement, or the IHI, as an approach to meet the what matters M. And it is a great whole health and kind of clinical care model for older medically complex persons to really help focus in on person-centered care that really helps align all the rest of those M's, including the mobility M. So we're going to start by talking about the first step, as you'll see here, that health type priorities identification step. So it's PPC really starts with the identification of the health priorities, and we kind of think of it in 4 core components. And this helps guide selection of therapeutic modalities, which will help them achieve a specific goal that you come to. And again, I'm going to kind of present them as steps, but it's really important to recognize that this can be a very fluid process, can be very nonlinear, can be really conversational style. It could be like actually a lot of the information of each of these different kind of core components can be achieved, gained and achieved by several different health professionals and care team members over the course of maybe days, and kind of put together by a team, right? Kind of, again, depending on your care situation and your clinical setting. But it's really done to, again, as a way to kind of get to know this person and what makes them tick and what works for them and what is really standing in the way of a goal that they have in that moment. So again, starting to explore what matters, and we'll talk about each of these different sections here, and we'll break it down. Setting a goal. We're going to identify a symptom, a barrier, or health task that's getting in the way of that goal. We're going to determine their care preferences, again, the things that they are willing and able to achieve a specific goal. And then we're going to prioritize all the things that are kind of in the way of that goal, and really maybe to pick a top priority or priorities to really focus in on as the point of the care discussion that day. So This is going to be another play along with me if you're willing. But we're going to talk about what it means to talk about values and ask about values. Now, patients are not really accustomed to being asked about their values by healthcare professionals. And we as healthcare professionals potentially might not also be very accustomed to asking about them. I think certain healthcare professionals, this is like your jam, and that's probably like therapists and psychologists and social workers, particularly. But some of us, we were not really taught this as the way to like obtain our history of present illness. And so it sometimes is a paradigm shift for us and for patients to like really start asking like what actually matters to you and not what is the matter with you. So I'm curious if anyone has any like go-tos when they are asking about what matters. And you can go ahead and again put those like questions in the chat, and I'll share a few that are recommended by either Patient Priorities Care or the IHI that I particularly like too. So you can kind of put some of these in the chat. But one of the ones that I particularly like is like, what makes a good day for you? What are some of the activities you bring you joy? Who are the most important people in your life? And what are some of the like, things you like to do together? What is the most important to you about taking care of yourself? Oh, I like that. Asking about what made you happy today. I think that's a great lead-in question. What do you hope your healthcare can do for you? And what would you be doing more of if you didn't have X problem? I think that was one of the ones I commonly go to. And please like throw in some other ideas if you have any. I've put links in the chat again to some of the like resources that are really, really helpful to try out different types of questions and get some ideas. So Mr. C, we explore his values. And when we think about values, we like to think about them in 4 different domains, and I'm going to go through each one of them. The first domain is kind of connecting, which is like our family domain. There's people and pets and like interactions and stuff that are really important to us. So as mentioned kind of previously, his veteran community was really important to him, visiting with his family and his particularly his church community. From an enjoying life, again, like all the things that are like fun for us to do, like entertainment wise or hobby wise, or quiet activity wise, that for him particularly was like, again, being outdoors, working in his garden, doing his photography. From a managing health, when we think about that, I think about how able and willing is a person to like, do the things that is required of their health, right? Kind of how good are they at managing their health and willing to manage their health and be organized about it. And for him, he was actually really willing to engage in healthy behaviors, and he liked a lot of autonomy around his healthcare decisions. He liked to partner particularly with his healthcare providers and not just have like a more paternalistic approach. And functioning, again, that's like kind of self-efficacy, purpose, being self-sufficient, that kind of domain. And as we mentioned, being physically active was really important to him, like being outside in nature, maintaining the house. He had a really high self-value perception and he felt very self-sufficient, and that was, it gave him a lot of purpose to be able to live home, live independently, and be able to do all those things on his own. So next, we move into like how to set a health goal, okay? And so by setting a health goal, we're kind of moving from values to something specific that the person wants to do more of that is related to those goals, okay? Goals are the activities that they want to do most of and that our healthcare hopefully can help us achieve. They should be specific and realistic. So therefore clearly articulate what's doable in their current life with their current health. And this is particularly true for mobility goals. And so I have found often that is very difficult to separate sometimes value statements from goal statements, but it's really important. And we're going to kind of talk a little bit about the difference between that in the next slide, but values are the bedrock to decision making. However, they don't really help align care in meaningful ways. Just saying like, I want to be independent, that doesn't give me something to like kind of put a specific, meaningful, like achievable goal around. What does it mean to be independent? It could be very different for one person to another person. And independence to one person could be that I am able to walk 20 feet to get to the bathroom on my own, versus another person, them being independent means that I can like leave my house and drive and, you know, go do all my grocery shopping on my own. Those are very different types of benchmarks and goals. And so that's why it's really important to kind of dive into that value of independence and get something really specific and realistic out of it. And so again, we're going to play a little exercise. So I'm going to, again, show you a goal, and I want you to tell me if you think it's specific or realistic or both. So again, we're going to do the chat, and I'm going to show you the first goal, which is I want to reduce falls. So do we feel like that is specific or realistic? Let's see if I can. Oh, good. I would say both. Actually, it is not very specific, but it's probably realistic, you know, in the context of Mr. C, you know, we probably are a lot of things we could do to reduce his risk of falls that are actually probably very doable. But like, what does that mean? Does it mean that we reduce like your risk of falling, you know, like 6 times a day to 2 times a day or 4 times a day? So I think it, like, again, kind of giving yourself a little bit of something that's a little bit more measurable around that might be a way to make it a little bit more specific. So the next goal is going to be we'll start exercising every day for an hour to improve my lower extremity strength. So do we think that is a specific goal? Curious. Yes, very good. Yes, it is a very specific goal, for sure. However, is it realistic? It might depend. It might depend. Maybe for Mr. C, who's like currently not really exercising and able to get out of his house, having to do it like an hour of exercise daily might be a high bar. You know, I personally do an hour of exercise daily, but that's something I've been doing for years. So that might be a realistic goal for someone like me. But maybe for someone like him who is not exercising at all right now, that might be a pretty high bar. And we'll talk about why it's not always great to set real, like, again, high bar goals for people, and maybe start with a more attainable lower bar goal. Okay. And then lastly, I improve my confidence around imbalance so that I can leave my house on a weekly basis. What do we think about that one? Sorry, I have to keep going to my chat that keeps disappearing. Both. Yes. Yes, we have zoomed in on a very good goal for Mr. C, and we will use this goal going forward. Excellent. Thank you for playing along. So here is our goal for Mr. C. Again, based on our conversation, he had the desire to actually get back out and walk more out of his house again and just start doing his photography. And so again, we see that we are putting some frequency and time duration around his goal, but we're going to set something that's probably going to be a little bit lower than what his prior baseline was like 4 or 5 months ago, right? Because he's not currently doing any of it. And so we really want to start with something that's a little bit more realistic. That might be at a lower level at first, but this is really important because, again, if we give people the permission, you know, oftentimes, especially again, when I have persons working with me as a physician, right? And particularly veterans who like see sometimes physicians as authority figures. They're going to want to set like really high bars because that's like what they've been conditioned to do. And I think that's normal for actually many different types of populations. And so I think it's really important for us as healthcare providers to offer permission and grace around goals and be like, hey, dude, I really want you to get back up to that, like, again, that hour of exercise a day, or that like leaving the house every single day to go take like 20 pictures, right? But I think it's really important to be like, but you know, before we get there, maybe that's our intermediate goal. Let's just see if we can just even start doing it once a week, you know, or maybe twice a week. Let's set something that's more realistic and doable so that you can achieve it. And by achieving it, that will reinforce commitment and confidence and in the progression of the further goals. Next, we're gonna start to focus in on what are the things getting in the way of that goal right now. Once we've identified something that's specific and realistic, we need to think about what are the different conditions, like something maybe fatigue or shortness of breath or imbalance, or is there a burdensome task like checking his blood pressure maybe multiple times a day, or blood sugar checks potentially. I mean, for other individuals, complicated medication regimens, for instance. Or are there like environmental or other psychosocial things that are like, again, standing in the way of a person's ability to do the thing that matters most to them? And so it's really starting to think outside the box, not just, again, symptoms and conditions, but all these other things too that could be contributing. And of all those different things, what is the thing that they really want to focus in on? And then lastly is kind of determining their care preferences. What things have worked for them in the past? Again, what therapies and medications or treatments have been really helpful? What things have not been particularly helpful that they would not ever want to try or do again? Or maybe they would if it was like this way instead, if that's possible. And what are they willing or unwilling to do or try? Because that will also eventually help with when it comes to the consideration and recommendation of things, really kind of funneling and specifying down what could be an exhaustive list to a very specific and very manageable list of things to start doing. There are some tools out there to kind of help this whole process. I just want to share them with you in case you, again, whatever works for your clinical workflow, but there is a myhealthpriorities.org website where older persons and their care partners can work together if they need be or by themselves to kind of go through this whole process and kind of come up with goals and actually print it out and bring it to healthcare appointments. And it sometimes is a really nice way to kind of help prime this conversation that oftentimes is a little bit different and at times can be jarring for not only just the clinical provider, but actually also for the older adult and their care partners too. So when we kind of put this together for Mr. C, we find out again that the bothersome symptoms in his case are particularly his imbalance and dizziness. And those are some of the things that are really kind of contributing to his low confidence with getting out of the house. When we talk about his health preferences, again, the things in green are some of the things he's like kind of willing that he has thought have been useful and helpful to his health or his care or have worked for him in the past. So you'll note the gabapentin he finds very important to managing health symptoms. And so it might be a harder medication for him to want to taper or come off of, versus on the flip side, the red things are the things that either hasn't worked well for him in the past, he doesn't really care to try or want to try, or medications, in this case tramadol, they doesn't really see any benefit from. And so this is a helpful way of kind of sorting out, okay, again, what could we go after? What could we recommend? Or what should we just like stay away from? Because again, he's already told us that he didn't really want to do that or he doesn't want to try that again. And so again, as I mentioned, we kind of focus in then on those in his case, those two things in the way. We asked him to pick a top priority that he wants to focus on. And with that top priority, we kind of start to think about what are the things that are contributing to that. And by now, if we get a person to kind of focus on that top priority or that issue, that troublesome issue that's standing in the way, we can really kind of start to bring this all together. So again, bringing it all together, we have his goal, which is that he wants to leave his house on a weekly basis, to do his photography. We know his bothersome symptoms are his imbalance and dizziness. We know his preferences. And so when we bring it all together, his top priority is to really start working on his balance and improve his balance so he can start leaving his house on a weekly basis. And that is his mobility goal that we are going to focus in on with our healthcare appointment that day. So with that goal, we're going to now start to think and consider all the different types of care options, things that are contributing to his imbalance, the things that we could do to address those contributing factors, and then focus it in on a discrete, list of things to start, stop, or continuing today that are feasible and effective that he can start to work on today. So when we think about care alignment, what's really important is thinking about the conditions and symptoms and treatments, again, that are contributing to a bothersome and that are impeding that health goal, and then once we kind of focus in on that bothersome thing or the symptom or complaint, and then thinking about all the, conditions, what might be contributing to that. And then based on that is then thinking about what are the potential medical or rehabilitative or social economic or other environmental things that could be interventions that could address the contributing factors that we have identified. So when I think about contributing factors, again, I put that burdensome symptom for Mr. C in the center there. And then, my geriatric concept map is kind of, this was seen on this slide. And, again, I think what's really important is to recognize that this is a pretty exhaustive list. It's actually pretty complicated to come up with sometimes, like in the moment, right? I mean, maybe some of us could have easily kind of come up with several of these things like in the moment, just even learning a little bit about Mr. C here. But I think it's also really important to recognize, even if you can only come up with a couple of these things, that's okay. And that's a good place to start. And this is also a really good opportunity to start to recognize and lean in and lean on your other interprofessional healthcare team members, because they sometimes can kind of fill in the holes and the gaps of other things that could be potentially contributing to Mr. C's imbalance, especially if you start to try a few things and his imbalance doesn't get better. So I think what's really important to recognize too is that when we do think about the burdensome symptom, again, it's best to just kind of expand our view outside of just the medical conditions or the medications, which we typically fall to, but also think about, again, the social economic factors, the psychosocial factors, the psychological factors, and the environmental factors as well. Based on that concept list, we then can start to think about, okay, what are some of the things that we could start to either start, stop, or continue that can address all these different bulleted points that are in that concept map and kind of bring it into this table. So, and in this case, I think what's really important is to actually start by that last column, which is the continue column. And it's really important to start there and to acknowledge what are all the things that Mr. C right now is doing that are actually already in service of his health goal. One thing I know specifically as a doctor is very easy to start with the start column and think about, oh, okay, here's all the things that we could start doing and add to your plate, Mr. C, to address your imbalance so you can start doing this healthcare goal. But by doing that and just adding more to his plate, we're already taking what is probably an already very full plate and trying to add and extend it even more. But instead, if we start to focus on all the things that a person is doing in service of their health goal, we start to elevate the good things that they are doing. We help them build further confidence. We build rapport and we build teamwork with that patient. And just recognizing how they are actually taking charge of their health. Next, then, it's actually helpful to go to the stop column and consider the interventions that might actually be worsening the symptom and thus impeding the health goal. These things might be, stopping or reducing, again, the medications potentially that he is on. And sometimes this can be particularly hard for prescribers, particularly if one of those medications is actually not a symptom medication, but particularly a guideline recommended medication. And that's sometimes where the conflicts sometimes, at least internally, can happen. And then last is to go to that start column. Again, considering the different things that people can do to achieve their health goal. As you can see, it's generally easy to come up with a pretty exhaustive list, particularly again, in the context of someone like Mr. C, who's already doing several hours a day of healthcare related tasks. Asking them to do one more thing can sometimes feel really overwhelming. And so I know personally, I have to catch myself very many times to not add too much. And so what I do then is this next step after this is I really start to think about grouping interventions, and particularly focusing, again, different interventions based on these 4 categories. And I use these 4 categories as a way to really think about what is, again, not only just strong in effect, meaning usually by evidence-based effect, but also what is feasible. So again, strong effect means the interventions that have been shown through evidence-based medicine to be the most effective in achieving a desired goal. So in Mr. C's case, that could be things that are shown to be most effective in building back lower extremity strength and balance, again. But by feasible, I also mean those interventions which are actually possible given Mr. C's preferences and his circumstances. Again, back to his health preferences. What is he willing and able to engage in? And what is he not able or willing to engage in? And that's really important too, because even if a thing is evidence-based and as the most effective thing, if he's not able or willing, or it's not even possible to give it to him, then it's not going to be useful and it's not going to be the best thing. So it's really, again, trying to think about what is the best or the safest or most effective for the context of the situation that we're working with that person. When sorting options by effective and feasible, it's really important to use, again, the patient's priorities as a guide to starting and stopping continuing interventions. By exploring different interventions, this is a way that we can, recognize that there actually is no one right answer to how do we get to a health goal. And it's also a good opportunity to recognize that even if this one thing doesn't work or these couple things doesn't work, there's always something else we can try. We can go back to our buckets and think about, well, okay, this thing didn't work, but maybe we can try this thing instead, and reach back into that tool shed. Again, this is an opportunity to kind of think more about, this is not a random approach, but this is like going to be guided by, again, your priorities. I'm going to do serial trials of things. By acknowledging from the beginning that we're not sure what's always going to work best, it actually helps recognize our humility in that moment. And it also gives us an opportunity to turn what sometimes can be uncertainty and no right answer into a positive space and really flip that kind of like paradigm so that we're offering patients hope and a sense of direction and empowerment in their healthcare. So in Mr. C's case, he wants to be able to leave his house on a weekly basis. And we also know what he's willing to do and that his imbalance is in the way. We know he's willing to be able to do some exercises, probably certain types of physical therapy. He doesn't mind using an assisted device, and that there are certain medications that he didn't find particularly useful or helpful that also could be contributing. And so maybe those are first places to start. Using these clinical decision strategies really help make patients feel heard and motivated, and that actually helps them adhere better sometimes to medical plans, especially because they already feel like it aligns with what matters most to them. They offer clinicians reassurance and an anchor as well in the face of uncertainty, particularly when there's trade-offs to things, right? The effectiveness of treatments is directly linked as well to the person's health goals, rather than, again, back to those disease-based outcomes alone. And we find that these decisional strategies oftentimes kind of get everyone on the same page, which is also really helpful. So when selecting interventions, this is kind of the 2x2 that I kind of came up with and how I personally kind of bucketed things in the context of Mr. C. And I think it's important to recognize is that, again, these things can be kind of fluid a little bit depending on any moment or circumstance. Maybe traditional PT is less feasible right now, but maybe in the future it will be more. Maybe he's not willing to taper his gabapentin today, but maybe in the future he'll be more open and willing to consider that. And so it can move again from something that's less feasible to something more feasible. Okay. And so this is kind of how I think, again, I organize things in my brain, maybe with my team, and recognizing that there is it can be some dynamics to this. But what's most important is, again, is it takes that really complicated start, stop, and continue table, and it focuses it down so that at the end of the day, we're not offering him, things from the orange and gray and yellow and blue bucket, but we're really focusing our recommendations to him on what's in that orange bucket. And so we took what have been very multifactorial, multi-interventional sort of approach and focusing it down to only maybe a few things in this moment that we will work on now, and recognize that we will check in maybe in a couple weeks or a couple months, see where we are. And if we're not where we need to be, then we'll kind of go back to the drawing board, back to these options, reassemble it, and then try something new. And so at the end, after reviewing kind of, again, our conversation and our analysis of what was most feasible and effective, here's the list of recommendations that I give to Mr. C. I think, again, is recognizing that there isn't just one right answer, and that one of the ways to choose to start is by, again, kind of focusing in on his health goal and and particularly the thing that's standing in the way of that goal, which is his imbalance. I think what's really nice too is that I think it's really helpful sometimes to organize it in this way, so that we can also recognize how we're doing different things, and even though his goal is in the service of a mobility, kind of goal, and we're actually thinking about all M's of age-friendly care when we are focusing in on that mobility goal. So there's many things that we're doing in the domain of medications and mentation that are in service of mobility, and that's all led by what matters most to Mr. C. There are many reasons why age-friendly care makes sense. The great, again, documentation of individual goals supports consistency among multiple providers and throughout the healthcare system. Again, it reduces treatment burden. We know that particularly even in the age-friendly and PPC literature, and that continues to grow, that this approach particularly helps reduce the receipt of things that are wanted and decreases healthcare that is unwanted and unuseful to older adults. It also maximizes the use of home and community services, which I think is really important. The age-friendly care empowers patients, and it makes us as healthcare providers, I think, feel more enriched that we're actually doing the medicine and the healthcare that we all, I think, signed up to do when we all chose a profession in healthcare. And I think the other nice thing too about age-friendly care is that it can transcend cultural backgrounds, and again, really uncover unmet needs and health disparities that can really preserve life and function. And so again, back to Mr. C, we're hopefully with this approach and this, conversation with him, we're going to reverse that cycle that I showed earlier in the lecture. We're going to start to improve his strength and balance, again, by getting him into a Tai Chi program, and specifically reducing his tramadol and some other medications that are, contributing to his mobility impairment and his imbalance. And by doing that, we're going to hopefully decrease his falling risk, sustain his mobility, or even improve his mobility. And that's all with exercise and just continuing that positive cycle. So here are some hopeful, useful resources for you. I can also put some into the chat as well, if that would be of use. And I just really appreciate everyone's attention, and I can take a few questions before I need to hop off and leave. So thank you so much.
I've tried to put some of those into the chat so they make it through there. They should be accessible to you if you download the PDF handout. Dr. Ritchey does need to leave a little bit early, so if you have questions and we don't get to them, please feel free to put them into the chat, and I'll see that we take them along to her. Thanks, Kay. That's helpful to. You've got them ready to go, the links.
Yeah. No problem.
I think this is a really helpful way of looking at age-friendly care related to mobility, because I like the fact that you sort of embed it or have it within the context of patient priorities and what matters, because that's really a key consideration for any of these M's that we have. Any questions from folks? Another thing to consider, because we have attendees from all different settings and all different disciplines, mobility is one of those considerations that's relevant for almost any group of professionals who are working with older adults. And so nurses, social workers, physical therapy, pharmacists, I can't think of even I was talking with someone earlier today about dentistry for older adults, and mobility is a consideration in terms of being able to get the care, that kind of thing, but understanding what are their priorities for getting that kind of assessment and care is really, really important. Sarah said this has been very helpful. Thank you so much, Sarah.
Thanks. I appreciate that.
So I know you need to leave, Dr. Ritchey. If you folks have questions, I'll leave the chat open for a little bit. Please feel free to share with your colleagues in the chat some experiences or lessons learned that you have gained from working with older persons and addressing mobility challenges and how to discern what matters to them related to mobility. Let me at least get the evaluation survey up here. I should have done that a few minutes ago. Sorry.
Well, thanks everyone. I really appreciate the opportunity. Also happy I can put my email into the chat if people have questions and they want to reach out. I'm happy to answer them that way too. And I'll put that in there.
Thanks so much, everyone.
Yeah.
Have a great week, and thanks for your attendance and your interest. Oh, Evelyn says, I love this patient-directed care while combining the medical focus, which allows for collaborative focus on future care. I think Geriatrics does a great job of interprofessional care and really a team-based approach. So I appreciate that comment, Evelyn.
Yeah, thank you. Thank you, Evelyn.
All right. Thanks, everyone. Have a good day
you.
and a nice weekend.
Thanks.